So please do just ask whatever questions that you have. We want this to be as useful to you as possible. So with the format, we're going to have a presentation for about 20 to 25 minutes. So as you're hearing it, please be thinking of your questions. And at the end of it, we're going to have a very brief case, but just trying to illustrate some of the problems that people after having COVID infection are suffering from, and then we'll have a discussion around the case, and then anything that you want to discuss. As far as how to ask your questions, it's really nice if you're happy to just unmute and pop your video on. It makes it much more interactive if we can see and hear from you. So please do feel free to do that, or you can write your question in the chat and I'll read it out and go through it. So I think that's everything I need to do around the format. Now, the most important thing is to know that the webinar's on fatigue and entitled In the Time of COVID, and Professor Trudie Chalder is kindly going to talk us through the area really of chronic fatigue after infection. And Trudie's a professor in cognitive behavioural psychotherapy at the Department of Psychological Medicine at King's College London, and she's also the Director of Persistent Physical Symptoms Research and Treatment Unit. We've got three other people on the call. We've got Hamish Macaulay, Wada Ibrahim, and I can't see her now, but Enya Danes is here as part of our panel. Hamish is going to go through a case, and Wada and Enya are going to help with the discussion to begin with while you're all thinking about your questions. So I think that's everything I need to say. So I will now hand over to Trudie to carry on from here. Thank you.
Thanks very much. Can you all hear me? Yeah.
Yep.
So I'm going to just talk a little bit about the evidence for post-infectious fatigue, the prevalence of it and predictors of outcome. I'm going to say a little bit about fatigue in the context of named flu viruses, such as the coronaviruses, and examine predictors of fatigue. And then I'm going to describe a couple of very brief interventions that we evaluated, focusing on fatigue. One study in the context of Epstein-Barr virus, and the other one in the context of people who had a diagnosis of cancer and were receiving cytotoxic treatment. So just to say something about the epidemiology of fatigue, the first thing to be said is that it's not whether you've got it or whether you haven't, it's how much of it you've got. So which is quite normalising. It's best viewed as on a continuum, with fatigue as a symptom at one end of the spectrum, and then fatigue and all its associated disability at the other end of the spectrum. It's 2 or 3 times more prevalent in women than men in the population, in primary and secondary care. In primary care, it's associated with psychological distress and lack of exercise. The most commonly cited reasons for fatigue in the population, interestingly, are psychosocial ones, in that people who are fatigued do know why they're fatigued, and it's usually because they're doing too many things, juggling children, working. Oh gosh, my slides seem to be going off here, there and everywhere. Another user took control. I can't seem to move back now. Sorry. Can we go back?
Is it on a timer, Trudie?
I haven't put it on a timer, no.
Hamish, do you know why we've got little gremlins?
I think someone may have clicked take control. So Trudie, if you unshare and then reshare, that should probably fix it as the quickest way.
And audience members, it's just better not to touch anything in Teams, isn't it?
I can't seem to go back on this computer, that's the problem. We practiced all of this and it all was going so well, wasn't it?
That's always the way, don't worry.
Just want to make, because I can't see them, knowing me, I'm going to end up with the wrong one.
That's great, we can see those again.
So let's hope that it's not on a timer, because I certainly haven't put it on. But anyway, here we are. There we go again. So, definition of fatigue. We'll start again. So, fatigue can be defined as extreme physical and mental tiredness. It's generally described as unlike the usual tiredness one feels when well, and it's distinguishable from drowsiness. It's a subjective feeling, so one can't really measure it objectively, although people have grappled with the idea for centuries probably. But it's something to be said about fatigue is that it's ubiquitous, it's everywhere, and it's associated with many illnesses. So as I said before, it's best viewed on a continuum, more common in women, associated with psychological distress and lack of exercise. Commonly, people attribute their fatigue to psychosocial ones, and it's the second most common symptom in primary care. This is a graph of some research that we did back in 1994 and earlier. The top graph shows you the prevalence of fatigue in the population. So as you can see, it's fairly normally distributed with a slightly skewed to the left, which demonstrates really clearly actually that it's not how much of it it's not whether you've got it or whether you haven't, it's how much of it you've got. In the bottom graph, we've got fatigue along the bottom and general health questionnaire, which is a measure of distress along the other axis. And you can see that distress and fatigue are highly correlated. And you see that correlation across the population, community, primary and secondary care. So I was interested, along with my colleagues, Simon Wesley and various other people, interested in whether common viruses were associated with fatigue subsequently. So many people who have fatigue, just in the population, believe that their fatigue started with a virus. Now, it's interesting that the average adult in the UK experiences between 4 and 5 symptomatic viral infections per year. So they're very common, and about 30% of a population sample answered yes to the question, have you suffered a virus in the last month? So clearly there are some chance associations between having chronic fatigue or fatigue and a viral infection. Now, interestingly, the association between having a virus and a common a fatigue, such an association was really at the stage that we did this study from retrospective case control studies, which we know are subject to ascertainment bias. And people do generally like to make sense of the world in which they're living and will make attributions for symptoms that they're experiencing, some of which will be correct, but some of them may be a little bit off. They may not have got the right causal attribution. So we carried out a case control study, which was a prospective design, and we were looking at the outcome of clinically diagnosed infections in patients presenting to the UK general practitioners. So these were people who were just attending the general practitioner, and then we recruited somebody, a control, as well as the person with an infection, and the control person was somebody with another symptom or another difficulty other than an infection. And we used questionnaires to assess fatigue and distress. These were sent to all patients between the ages of 18 and 45 in the study practices prior to being recruited into this study. So we already had a measure of their distress and their fatigue before being recruited, which was quite helpful. So the prevalence of chronic fatigue and chronic fatigue syndrome was ascertained among over 1,000 people between the ages of 18 and 45 who presented to the GP with a symptomatic infection, and in another 1,000 or more people who attended the surgery for another reason. Followed 84% up at 6 months. And interestingly, 9.9% of the infection cases and 11.7% of controls reported chronic fatigue. So there was no difference between those two groups. And there were also no differences in the proportions of the two groups who met the various criteria for chronic fatigue syndrome. Now, the strongest independent predictors of post-infectious fatigue were having reported fatigue previously, as in those people who attended the GP previously with fatigue. They were more likely to have fatigue subsequently. In addition, distress assessed prior to the GP attendance or at the time of the acute infection, they were also more likely to be associated with fatigue subsequently. So this study showed that there was no evidence that common infections, so common colds and flus in primary care, were related to the onset of chronic fatigue or chronic fatigue syndrome. So what about more serious viruses then? Several of my colleagues have done lots of research around the world looking at the role of these more serious viruses and the development of fatigue subsequently. So most of them have found some evidence that the more severe infections, such as infectious mononucleosis or IM, that these infections could contribute to fatigue syndromes. And collaborated fatigue following infection. It was called COFI or coffee. So these prospective cohorts were recruited from the UK, the Netherlands, Norway, USA, New Zealand and Australia. And they had over 3,000 participants from 9 different cohorts. And as you can see there, they had a variety of different infections, including infectious mononucleosis, Q fever, Giardia, Campylobacter, Legionnaires and Ross River virus, which I think is from Australia. And follow-ups were between 6 months and 10 years. And these studies all used the Fukuda criteria for chronic fatigue syndrome. So what did they find? They found that the risk factors for non-recovery were low physical fitness, female gender, which seems to be fairly consistent across different studies, severity of the sickness response at the start, and autonomic dysfunction, which would kind of imply that people's level of arousal or anxiety. So a very good PhD student of mine who's interested in fatigue in general decided that when the pandemic hit, she became interested in this because she'd been living in the Far East when SARS and or MERS hit. So she was quite used to thinking about living in the context of a pandemic. So she agreed that she would do this systematic review of fatigue following a known flu virus. So this is about to be submitted, but I'm just going to present one aspect of it very quickly. That she included 10 studies that actually met the criteria for a pooled prevalence analysis. She found that the fatigue prevalence was around 41%, and that was out of a total population of 1,310 people. And interestingly, the most common psychological factors associated with fatigue were post-traumatic stress disorder, depression, anxiety, female gender, and old age. And interestingly, at 12 months after the infection, the pulmonary function and exercise capacity had gone back to their normal range. However, people were still experiencing quite a lot of profound fatigue. And interestingly, people exercising to the fatigue itself, despite the fact that their exercise capacity was normal. So just to say that whilst there is this very strong association with psychological distress, this was found in many of the studies, but not every single one. But bearing in mind the epidemiological findings that I mentioned at the beginning, there is a clear relationship, a high correlation of about 0.6 between distress and fatigue. But it's important to note that in these population studies, having distress in the context of an illness, and certainly in the context of a pandemic such as this, distress is understandable, but it's not necessarily a psychiatric disorder such as anxiety and depression. And I think therein lies one of the difficulties that everybody's grappling with in mind-body health at the moment, that quite a lot of people do feel distressed, understandably, but not necessarily depressed, or indeed they wouldn't necessarily fulfill criteria for an anxiety disorder. So how to intervene? Well, I just wanted to say something about this particular study that was carried out in 1964. It was after I was born, but certainly not at a time that I can remember. So this was a quasi-randomized trial of 131 patients with acute glandular fever. And I'm not sure that we'd be able to do this now, but he assigned patients to either infirmary bed rest or unrestricted activity. And interestingly, 21% of those people unrestricted activity versus 47% who were assigned to bed rest experienced symptoms at 21 days, which implies that the more active people become early on at the time of the infection, seemingly the better the outcome. So interestingly, it begs the question as to whether we can prevent fatigue after infections. And some years ago, with Bridget Candy, who was a research nurse at the time, working with us, and Matthew Hotoff, and various other people, we tested the hypothesis that a very brief intervention, which included one face-to-face appointment with the patient when they had a definite diagnosis of EBV, plus 2 subsequent telephone calls, which were quite brief, delivered by the research nurse, which was Bridget Candy. This was delivered shortly after the onset of the glandular fever. We hypothesised that this would reduce fatigue symptoms at 6 months. And the information that we discussed with the patient, or the content of the sessions, was reinforced with a booklet. In that conversation, Bridget really concentrated very much on lifestyle management. So some advice about returning to work as soon as possible, but bearing in mind they'd had a nasty infection, and not to go sort of training for the marathon, particularly if they'd never been out on the treadmill before. You know, some sensible advice about not doing too much too soon, but also emphasising the importance of trying to get back into some activity, and then very gradually increasing it. Now, many of these people were young people. It's a young person's disease. That's probably why it's called the kissing disease. And people also were given some advice about the importance of a sleep routine, as many of these young people were kind of burning the candle at both ends. So it was sensible advice. And what we found is that, as you can see here, is that at 6 months, those people who got the intervention from the research nurse, who wasn't a trained therapist, by the way, that they were less fatigued at follow-up. You can see there's it took a little while for that separation to occur, sort of suggesting that there was a bit of a delay between the time being given the information and the time that the information really had an impact. So similarly, we asked ourselves whether the same kinds of approach would be helpful in people with chronic diseases. So we did something very similar in people with cancer. So we randomized patients to 3 sessions of a behaviourally oriented psychoeducational intervention, again with a nurse, and we compared this with usual care. So these were consecutive patients who were receiving quite nasty treatment on an outpatient basis. These were people with a variety of different cancers, as it was really a feasibility study. So in terms of the actual sessions, there were 3 one-hour sessions over 9 to 12 weeks with the nurse. The first one really was an assessment of the patient's difficulties or struggles. And then the second session was really focused on some activity planning and some sleep management, emphasising the importance of an uptime and some bed restriction if people were using bed a lot for rest in addition to sleep. And then the last session was really about both increasing activity if it was appropriate and addressing any unhelpful thoughts that were interfering with their ability to carry out their activity. But mostly, having talked to Jo Arms, who's a research nurse in cancer, she said most of it was behavioural, and people did, once reassured, did feel able to make some changes with what they were doing. See here, this is the change over time in the 2 groups. You can see it at time 4. I can't remember exactly what time that was, but that was after they'd finished towards the end of their treatment. You can see that those people who got the intervention, which is the red line, that they were a lot less fatigued than those people who got the usual care. And interestingly, in terms of their physical functioning using the EORTC, those people who got the intervention were also functioning much better than those people who got treatment as usual. On this particular graph, you can see that a higher score is better functioning, and it had an impact. And this was despite the fact that people were undergoing nasty treatment and in the context of adjusting to a nasty disease. And I think this illustrates really that the treatment of fatigue doesn't have to be outside of the context of other treatment, and that even though they had a very clear-cut disease and a particular pathway that they were still on the journey with, change was possible. So, in summary then, fatigue is a ubiquitous symptom. It's everywhere. Everybody has it to some extent or another. It's particularly problematic in chronic diseases, and you see that the fatigue usually starts in the acute phase of the illness. You see that in relation to severe viruses. But once the treatment of the acute condition has finished, then the fatigue that people are experiencing may well be caused by a number of different psychosocial factors. And in fact, the longer that people get away from the actual virus itself, the more likely it is that those factors are going to be playing a very important role. And from a transdiagnostic perspective, the affective, cognitive, so the way in which people think and behavioural responses to fatigue may really be similar across these different diseases and may respond to similar treatment approaches regardless of the specific diagnosis. And that's it. Thank you.
Thanks ever so much, Trudie. Hamish, do you want to go into your case? And then audience, if you can be thinking of your questions and popping them in the chat, that would be great.
Hamish, you're muted.
Thank you, Wada. So I'm Hamish McCauley. I'm one of the clinical research fellows working with Rachel on the FOSS study and in the post-COVID clinic occasionally. Just going to present a very brief case, just to sort of frame the discussion. So this is a lady I saw about a month ago in the post-COVID clinic. It's a 38-year-old lady who was previously completely fit and well, lived with her husband and 2 children, 12 and 16, so relatively grown-up children. She'd worked in finance many years ago, but was now a stay-at-home mum. So her acute illness was in April 2020. She had very typical COVID symptoms, so fever, cough, breathlessness, and some palpitations. She didn't have a swab at the time because she was never admitted to hospital, but she did contact 111 on a few occasions, particularly due to her palpitations, and ended up in A&E at one point. She had an ECG, which was normal, or I think she had sinus tachycardia, but she was reassured and because her oxygen levels were fine, and discharged home from A&E. So her early recovery, as I mentioned on the previous slide, she was fairly unwell for about 3 weeks, she described, but then after that, she was still very tired, and she noticed the palpitations continued. So every time she tried to do anything, she'd get these palpitations that would stop her from doing very much. She contacted her GP repeatedly and had one further A&E visit, again with palpitations, which again, a sinus tachycardia ECG. And she felt very fobbed off by doctors and us at that point. She felt that she hadn't recovered from her COVID at all. She was still really unwell and really couldn't start doing anything. But actually, at that point, she hadn't yet developed what she now really struggles with, which is a lot of muscle aches and joint pain. So that came nearly 2 months after she'd initially been unwell. And those, she noticed, they would never come on when she was doing something. They would always be the following day, or after she'd been doing something. That night in bed, they would wake her up. So it was quite unusual symptoms, or she thought. So eventually her GP did, her GP certainly wasn't ignoring her. I think they were trying very hard, but with limited options. They referred her quite early for pulmonary rehabilitation, which there was a bit of a wait before she was able to get into it. And I'm not sure if it was pulmonary rehab or just rehab, but she had a rehab assessment. She was given a trial of sertraline, and then because that actually made her palpitations worse, she was stopped that and referred to a psychiatrist. She was referred to a cardiologist for these palpitations, and then referred in to the post-COVID clinic, which is when I met her after she'd seen all of these other people. So the cardiologist had given her a clean bill of health and said that her heart was absolutely fine, and was delighted with that, but she wasn't really reassured. She was still waiting to see the psychiatrist, but she didn't really see where that was going because she felt it was the fatigue that was her problem. And the pulmonary rehab, she was absolutely terrified of, because she'd done her pulmonary rehab assessment, which involved a bleep test. I think it was an incremental shuttle walk test. And she'd done that, and she'd worked as hard as she could. And she said she couldn't get out of bed for 2 weeks afterwards. Absolutely laid flat. The worst symptoms of fatigue she'd felt at any point was for the fortnight after her pulmonary rehab or her rehab assessment. So by the time I met her, I didn't know really what to do. I had this very friendly young lady who came with her husband, and she was very personable, but very, very upset and distressed and frightened. She'd gone from before her COVID admission to being a fit young lady, park run. She was well and active and quite keen to get on with life. And now she felt like she was unable to get out of bed in the morning, and was terrified of overexerting herself, even coming to clinic. So I think that's all I've got to say. So I'll stop my slides and we can have some discussion.
Great, thanks Hamish. And I think those of us doing post-COVID clinics, that's not an uncommon scenario with this post-exertional fatigue. And Trudie, I think we'd be really, we welcome your advice really on what should we be saying to these people, because you can see the story, isn't it, of being referred here, referred there, referred wherever, but actually she hasn't, despite all of that. And Hamish was politely saying, well, you know, one specialist has said, oh, well, it's not this organ, off you go, which is actually is really unhelpful, isn't it? Not there, I'm not blaming that specialist. We, you know, we're all guilty of doing the same thing, but how, you know, how do we actually tackle the problem that she's experiencing?
I suppose I would, the first thing is, I think I can understand where she's coming from, not wanting to be seen by the psychiatrist, because as she says, her problem is primarily fatigue. So I think that's where the rehab clinics come into their own, really. I think that there's a that I'd want to ask her. First of all, you know, what was going on in her life around the onset of the pandemic, because obviously she got this virus right at the start, at the beginning of April. So I'd be interested to, because you say that she's a stay-at-home mum. She's got 2 young children. I don't know how old the children are. Did you say?
I did. They were 12 and 16, so secondary school age.
Okay, yeah.
So to Hamish, they're old, you see.
Yeah, fair enough.
So, but she's and I wonder whether there's anything else been going on in her life at the time of the pandemic. Know a little bit about whether she's ever had anything like this before, whether she's ever had a history of fatigue or somatic symptoms, or indeed anxiety, because she sounds quite health anxious. And what expectations did she have of herself? Because from what you said, I can't remember which particular, there was something that you said that made me think she's a lady who has high expectations of herself.
So certainly all of those things came up in our conversation, because she was, for her, half of it was the fear and frustration that she was quite fit. So I mentioned running. She did go running, several times a week. And she wasn't even dreaming of going running again for the rest of her life at the point that we were talking. So she had expectations that she should be doing things that she was never going to be able to do again. I must admit, I didn't discuss with her what had been going on before she got COVID in that immediate time. That didn't come up.
Just in terms of her expectations, once she'd gotten over the acute illness or sickness, had she tried to go back to running in the way that she had previously? So she had a kind of, even though she'd been quite sick, had she gone for gold then suddenly?
So in that hiatus, before, when she'd sort of started recovering, but before she started getting the joint pains and aches, she mentioned that she'd gone for it was when lockdown started to relax a bit and you could travel for exercise, moved to the Peak District for a walk with her husband and kids, and they went for a few miles, and again she mentioned that as one of the key moments when she realized she couldn't do what she'd previously done. So she tried and felt that she couldn't. Yeah,
so the Peak District's quite hilly, isn't it?
Yes.
I think it's quite, people underestimate how hard hill walking is, and I think when if you're doing some distance, it can be quite demanding. So I suppose the first thing I might do is to acknowledge her difficulties. You know, it's understandable she felt fatigued, because she probably did have quite a nasty illness. I mean, we don't know whether she did or whether she didn't, but it sounds like she had the symptoms, but that probably she did try and get back to her normal self rather quickly. And of course, she's probably got quite a lot on at home with the children. And I suppose the other, in terms of where she's at now, I think that is addressing her fears. You could say the research suggests that people do get better from this in other nasty infections. But the important thing is to start with where you are now, because whatever you were doing 6 months, 8 months ago or whenever it was, you clearly can't do that now. And being an athlete, you probably will understand that pretty well, that you have to start at where you're at, not where you would like to be, if that makes sense. And that the important thing is doing something very, very small and often in the first instance, even if it's just a little, I don't know what she's able to do now, but given that she went for the walking test and then spent 2 weeks in bed, she's clearly I mean, that's quite an extreme behavioural response to that, isn't it? So, and it sounds like she's very, very health anxious. So I would be starting off with very small goals that are very easily achievable in the first instance, so not to make her feel more anxious about it. And then to think about an approach called is called acceptance and commitment therapy, but to some extent it's setting your goals at a level which are very manageable and being able to carry them out even with a small amount of fatigue. So despite this fatigue, are you able to make a small step towards reaching your goal? And it wouldn't matter how small that is. It sounds like the Peak District was just a bit too ambitious at that stage.
Yeah, so Trudie, I also had a similar case, a similar age lady actually, a nurse that was fit and well, runner, cycler, and she'd also had that expectation, well, I'll be a bit ill for 2 or 3 weeks, and then she said, I'm back to work, and she actually went back to work and cycled to work, right. And then was absolutely wiped out in a similar way. Yeah. So what should we be, when somebody's leaving hospital, it's so difficult at the moment for us to know really what to say and when to refer to rehab. We've got a better idea now to at least say a bit more about the trajectory, and that some people are, do end up with symptoms for a long time. But can you give us some sort of tips? I suppose at stage, is there anything we should be saying at that discharge, or do we just say, see how you go, and then we normally follow people up in a few weeks and take it at that point? Or should we be giving a bit more structured advice about?
I would say this is a nasty virus. It's nasty. I remember I broke my ribs for the first time ever in my life, and I got pneumonia one Easter, and I'm usually somebody who's quite active, and it really, knocked me for 6 for a little while, in that I couldn't go back to doing exactly what I wanted to do immediately. And I think I would say to her, you've got to take this seriously. You've had a nasty, or whoever it is, to your patient, you've had a nasty virus. You're not going to be able to go back to exactly what you were doing. So the important thing is to be mindful of the amount that you feel you can do at the moment, but whatever it is, do it regularly. Because
it's regularly. Do you mean that every day?
Every day.
Well, I might be too precise now.
No, I think it is good to be very precise. Yeah. Actually, I think to do, if it was walking, you might say, even if you can't do more than a 10-minute walk, a 10-minute walk is fantastic if that's what you can do every day. If you can't do a 10-minute walk every day, do a 5-minute walk every day. But after you've done the 5-minute walk every day, you can increase it to 10 minutes, and then you can increase it the following week to 15 minutes. So it is quite helpful, I think, to be very precise, but to say, look, it doesn't matter how little you can do. The important thing is the consistency at the stage. Yeah. But that acknowledge that this is nasty. It's if you've broken your leg or something, you don't necessarily feel ill, but the rehabilitation really does take quite a while, doesn't it?
Yeah. And that reassurance that it will get better. I think that was one of the first things that you framed the response back to Hamish's patient. Wagda.
Thank you, Trudie, for this great presentation, and thanks, Hamish, for the case. I think this sums up quite a lot of patients that we've come across over the last few months. My question was, I'd come across a report a while back that looked at patients with lingering fatigue post-COVID, and this group of patients was disproportionately made up of women with history of anxiety and depression. Mm-hmm. So if this group is found to be the group that is going to suffer with fatigue the most, what's your insight on early intervention, whether that be behavioral or pharmaceutical, even early on in the infection or immediately after discharge? What do you think?
I mean, it's right that more women than men get fatigue. They certainly have they have hormone. There's all sorts of different contributing factors. So I suppose the first thing I would do is to acknowledge that they've got the fatigue problem. Talk about how it's multifactorial. Often you find that at periods in people's life, such as adolescence and during the menopause, that hormone dysregulation and change in hormones makes people more prone to fatigue. They've also, I mean, I think the menstrual cycle also in the mix. They're all often also juggling work and children and managing an awful lot of things, which does contribute to their fatigue. They're also more likely to be experiencing anxiety and depression, because we know that the prevalence of anxiety and depression are higher in women. So I think what you say is, look, we have to put everything in the mix, you know, that it's never one thing. It's usually, sometimes I think the virus is the straw that breaks the camel's back. You know, people are already at their capacity. And then suddenly something comes along and you think, I haven't got time for that. You know, it's a bit like at the moment we're all stretched to the limit. And then if we have a death of a loved one, or, you know, you suddenly, I don't know, something else happens. It could just be the thing that tips you over. Yeah, so I think it's important to put it like that, in context. And then I think in terms of the with stress, anxiety, depression and fatigue, I think it depends what the person is saying is wrong. If they're saying to you, look, my main problem is fatigue, I would focus on that. Because otherwise patients will feel fobbed off. They are going to feel, well, you're saying this is depression and anxiety, and so they'll think you're implying it's all in their mind rather than the fact that it's a real problem. Yeah. So start with where the patient's at. If it's fatigue, then start with that. Say that we know that there's a relationship with distress, but we know that even with distress and fatigue, I usually say a little bit about the arousal system. So the HPA axis is involved in distress, and when you're feeling distressed, your body has this way of telling you you're stressed, even if you don't know yourself. And that hormones are likely to be dysregulated in this experience that you're having. But that irrespective of whether you're distressed or you're fatigued as the primary thing, that graded activity and doing what matters to you in a graded way and getting back into your life in a very graded way is going to be helpful. So in a sense, if you focus on the processes that are wrong, you know, or difficult, like their sleep routine, whether they're still seeing loved ones, or are they seeing their friends, are they having a chat with somebody, or have they, because if everybody closes down and in a sort of protected way, it might help in an acute phase, but it's not going to help long term.
Yeah. Rosemary Brown, you've put some comments about your experience in the chat. Would you be prepared to just pop your video on, and
I'm on. I'm here.
Lovely.
Hi.
Hello. Hi. So
Hi,
you were saying that you also use the ACT that Trudie's mentioned. So do you want to just take us through your experiences rather than me reading out what you've written?
Yeah, that's fine. So I'm a therapist working in a chronic fatigue service in Bristol, but I also work in neuropsychiatry as well. So there's some similarities and some differences. And I find I'm a psychological therapist. I'm probably the last person a lot of people want to see, to be fair. But I find using the sometimes connecting with people using the acceptance and commitment model is a much nicer way, because you can frame it around what their values are and identifying what their rules really. So, you know, their shoulds, their oughts, you know, in order to be a good parent, this is what a good parent looks like. I can't do those. So really trying to connect with them on that level can be a much nicer way in to having a helpful discussion and talking to them about, actually, you know, we don't, sometimes when all those rules are in operation, we're not actually doing the things that are helpful for us. So I just find it such a lovely tool to use with people. I was just sort of being supportive of what Trudie was saying and saying how that could be a really nice introduction. What committed actions are you taking towards?
That's really
you know, like the lady that you were talking about, that she should be able to do. She should be able to. You might unpick quite a lot of very fixed rules about what she should be able to do, and actually you can take a step back from that and think, actually, how's that getting in the way? Is it taking you towards being the kind of person and the life you want to be leading? Is a less, and it feels a little less psychological for people.
Very behavioural, which is good.
Yeah, committed action. I like it.
I don't know about the other clinicians, but I feel like I just need to do a whole load of upskilling training. But I think this is the type of thing that actually you can bring into your consultation if we just have a bit of, knowledge of how to use it and frame our conversations quite differently. And like Hamish was saying, I bet if I go through all the people I've seen back since June in the post-COVID clinic, some I will absolutely understand. All the things that were happening leading up to that. So I bet that is missing. So I'll definitely take that away. I'd like to bring a couple of our physiotherapists into the conversation who have been in the chat. So that's Lindsay Houchin and Barbara McCready, because obviously we're from in respiratory long-term conditions, everything's about exercise rehab, getting people up, doing more, and we're just sort of thinking really how to be tailoring that recovery program. So Lindsay, if you want to start with a couple of the comments that you've made and questions for Trudie.
Yeah, can you hear me?
Yeah, perfectly.
Lovely. I'd just put in the chat about, obviously there's quite a lot of anxiety from the chronic fatigue syndrome and ME community, particularly on Twitter and things, about doing graded exercise therapy and rehab. So I was just wondering what other techniques people use for people who are having these real issues with fatigue after either a rehab assessment or class. And I think Enya might chip in to say I don't think that's generally been our experience to date of the people that have come to the rehab classes.
That's good. I mean, I think the first thing to say is that there's an awful lot of Twitter going is particularly in engendering fears and concerns in people who are going to be a bit anxious about their health after they've had a nasty virus. So, but I think I would always say start with where the patient's at. Even if it's starting with walking, you can always progress it to something a little bit more, more demanding as time goes on. For the very, the people who push themselves to the limit and the people who are overdoers and try to go for goal too quickly, I think it is important. Somebody mentioned that you might want them to do slightly less in order to be consistent. It's a bit like with running. If you just go out for a run or a big walk on a Sunday, which is what the lady did that was presented, but have not done any preparatory work for that leading up to that big walk, it's not going to work. I would say that exercise clearly is not damaging to people, and I always say that the harm done to one's health, or the lack of benefit to health, is far worse than any the advantages of exercise far outweigh the disadvantages. Does that make sense? As long as you start at a level manageable.
Yeah, no,
which is what you've all been saying. You rehab people, you've been saying this all along, I'm sure. I'm teaching my grandmother to suck eggs here.
Well, we're asking you the questions, and I think that's very helpful, because it is slightly different to how we cope with some of our exercise training. Is very much high intensity aerobic training, particularly for like heart failure, COPD. So this is slightly it is different.
You do high intensity COPD.
Yeah, right from. So this talking about that, obviously it's done in context with the individual, but Barbara, do you want to, you've particularly mentioned the cognitive fatigue, and we're absolutely seeing a lot of that in the clinic. Are you still here to add?
Yes, yeah.
Lovely.
Yeah, can you hear me? Yeah.
Can hear you.
Yeah, absolutely. We're working with kind of some of our occupational therapy colleagues as well, and some of our neuropsychology colleagues, and we've referred a couple of people across actually to the ABI team. for some really kind of in-depth assessments for cognition. Now, I can't tell you all of their assessments because they go into great detail in terms of the cognitive side of things, but even some of the patients that we're seeing that initially we had real worries about in terms of cognition, that were on really high levels of oxygen therapy, and we were worried that potentially there was kind of a hypoxia element. Actually, when they've dug really deep down into those kind of cognitive assessments, they have identified that most of it is actually fatigue. And when those patients are really pacing their activities and planning things out, that actually their level of cognitive kind of abilities, it significantly improves. Working with them, we've kind of realized how much we have to tailor that activity levels. From a physio point of view, I'm often telling people to kind of slow down and to take the time a lot more than you know, we would normally within our pulmonary rehab, for instance, where we would be pushing that intensity and trying to kind of make them work a lot harder.
Yeah, no, that's really helpful. And Robin, I think you've got your hands up. I apologise to you and Enya because you might have had your hands up for a while and I was looking at the chat, so sorry about that. Robin, are you there?
Yeah, hi there.
Hi there.
So I work in a post-COVID clinic in London, actually in a private hospital. I am also in the position, unfortunately, I was probably one of the people that Trudie would have described as being pushing everything to the limits. 4 days before I had my first symptoms, I did a 24 half marathon. And I think the point I was going to make, not so much about my story, but I have seen lots of people like me who, yes, have been very highly driven and have probably been on the edge, and we've done all the acceptance bit with them. But I think we've got to be very careful with people with exercise, because there's people presenting in different ways. We've got people who have got post-viral fatigue that we are seeing in our clinic, that the pattern that Trudie is describing of just gradually just getting a sustainable baseline and nudging things up very gently is working really well for them. The people who are more on the chronic fatigue type pattern, which unfortunately I'm on as well, exercise is active, without a doubt. We have got people that are doing CPET tests that are really struggling, as in that and it's not so much the psychological elements of it. They literally, the legs are given away underneath them. And people I had a guy who was doing 300 watts on a 6-hour cycle before COVID. He was doing 50 watts for 20 minutes and then couldn't cycle for 2 weeks afterwards. So I think there's very different paths. There's some people that fit the pulmonary rehab picture. There's some people that we push them on, they do really well. We've got the people who have got the post-viral fatigue, take it very cautiously and they do well. But there's other ones that we've really just got to try to get them living their lives. And when they do try to nudge up above their sustainable baseline, they go backwards. All their symptoms get worse. And they don't want to be getting back to running marathons, doing 6-hour cycles. They want to be able to do a gentle walk, okay? And they can do it, but it has a massive impact. So I think we've got to do it a real case-by-case basis. And these various different presentations that people are talking about, we've really got to pay attention to them.
Yeah, no, absolutely. And hopefully the research will also inform a bit more of that, won't it, as we get going with it. Thank you, Robin. Yeah. Enya, I think you had your hand up, and then there's a couple of bits. I'll bring it to a close.
Yeah, I thought it would just maybe be helpful to share our experiences from rehab, in that I appreciate what you're saying, Robin, and we've been quite apprehensive about over exercising people and make sure we're being mindful to work them within their symptoms. So far, although obviously we've started reasonably recently, we've not had too many people complete, but in about the 20 people that we've had complete rehab so far, none of their fatigue have got worse, and that applies to kind of their cognition and their physical fatigue as well. So I think that's reassuring in that we are doing the right thing, but obviously, as you were saying, Robin, we are just trying to be aware of those people that aren't benefiting in that way and making sure that we work with them when we need to. But I think there's similar things to what Trudie mentioned earlier. The people we're seeing who are really fatigued are those people who have higher expectations of themselves and are not as able to kind of bring their activity levels down. So when they've got children and they don't have much choice but to look after them and take them to school or whatever it might be, those are the ones that seem to be suffering more. So they can be quite emotional conversations. Often we'll have some tissues at the ready for things like that. So everything you're saying, Trudie, is kind of our experiences. I just feel slightly guilty about that patient Hamish mentioned, that I clearly pushed too hard on the walking test. And I think the difficult thing about walking tests where we haven't had this issue before is that usually it's limited by people's breathlessness and they can feel that right away, whereas when they're limited by fatigue, they maybe don't feel that until the next day or the day after that. And we're very mindful to ask people to stop when they think they're in their limits. What would normally make them fatigued. But
can I add something to that? I mean, first thing to say is that I think when you're dealing with athletes who have been, you know, they've had a fine-tuned body, let's put it like that, and are really exercising a lot, you have to, then it's worth drawing on the literature on overtraining, and cyclists in particular have that ability to shift over into overtraining quite quickly because their heart rate is, they're training with their heart rate being quite high for a very sustained period of time, unlike runners, funnily enough, or other types of exercise. So that's the first thing to think about overtraining in athletes, because that affects the immune system. It's a bit like racehorses. If you overtrain them, they can't race on the day, and it is their performance sick. You can't, it's quite hard for them to recover for quite some time. And the other thing I was going to say is I don't think you should blame yourself for that, because I think it's not just what you did that resulted in the person being in bed for 2 weeks. You have to remember that the way in which any of us respond to symptoms that we're experiencing is all that behavioural response is going to be influenced by our thoughts and our feelings too, and that people worry, you know, that when people have a huge worry about the symptoms they're experiencing, it is going to affect them behaviour. You know, they may actually behaviourally respond in a way that isn't necessarily helpful.
Yeah, and I think that's when people are quite apprehensive, like Hamish said, about coming to rehab to start with, but actually once we've had more time to build that relationship, we have noticed everyone has improved their fatigue throughout the programme. So it just takes a little bit of time, and it may be a little bit more convincing to get them to that point. But once they're all started and we have time to work with them, they are improving, which I think is quite useful.
And Trudie, Trudie, you have the last word and then I'll wrap up.
I was only going to say that for me, walking is exercise. It doesn't have to be running and cycling and, you know, doing somersaults.
Yeah, no, absolutely. I do feel that we could carry on for another half an hour with various things in the chat and this discussion, and I think we are in a bit of an evidence-free zone with COVID still, so it's really helpful, Trudie, for you to come in and share your, you know, very vast experience about managing fatigue. And I think most of us as clinicians and researchers have heard some really useful things that we'll be able to take away. I just want to highlight that, I've lost it now in the chat. I think it was Ruth that has put down that there are some resources. Sorry, I now can't use my my mouse. Sorry, in the chat there was something about resources around ACT. Able the links that would be really helpful so that we can have a look through and at least, you know, upskill ourselves a little bit in our consultation skills to help this group. I think with rehabilitation, there's lots of things to think about, isn't there? There's the timing, because we haven't discussed that today. I know in the chat there's things around physical activity, step monitors, strength exercises, so a whole host of things that we probably need to do more research on, really, to think about what that optimal programme is. But thank you so much, Trudie. That was really very, very helpful for us. And thank you very much to Hamish, Wada and Enya for being part of our panel, and to all of the audience for being so engaged. Found it useful. Found it. Thank you ever so much. And the last thing to say is that we've got our final webinar of this autumn series next week, which is actually on recovery and rehabilitation programme, so that will follow on nicely. Hamish, are you able to just pop that the link in the chat? All right. Okay, well, enjoy the rest of the afternoon and evening, everyone.
Thank you.